Welcome everybody to this Reoxcare video. Today we present the experience of Italian Professor Corrado Maria Durante in the use of Reoxcare line of products. We collaborate with our partner in Italy, Factory Italia, represented here by Angela Andreoli. Angela, welcome.
Welcome. My name is Angela Andreoli and I am Director Sales and Marketing at Factory Italia. Factory Italia is an Italian company very committed in natural wound care treatments. Today, I have the great pleasure to welcome a leading wound care KOL to our interview, Professor Corrado Maria Durante. Professor Durante is Professor of Wound Care at La Sapienza, Tor Vergata and Catholic University of Rome in Italy. He is a specialist in plastic and reconstructive surgery, especially in general surgery. He is also Medical Officer, Brigadier General of the Italian Army Medical Corps. He is also Senior Plastic Surgeon Consultant at Traumatologic and Orthopedic Department at Army Military Hospital in Rome. His training started from general surgery, but his professional development folded in reconstructive surgery in the area of skin injuries, soft tissue loss, and complex wounds. Professor Durante is very committed to the branch of wound care, ulcers, sores, and non-healing wounds. Being a medical officer, he participated in several humanitarian missions that had a great influence on his professional growth. I leave you the floor, Marta.
Thank you, Angela. Now, Professor Durante, we will start with the questions. First question, could you briefly explain your experience in wound healing?
Thank you for the question, Marta. As Angela told us, I'm a plastic surgeon and many years that I'm involved in the wound care and as a plastic surgeon with a surgical procedure, of course, but also with the application of the hyper-technologic dressing, all the special of dressing related to the different types of wound that I observe in the hospital. Recently, I'm the senior plastic surgeon consultant of an orthopedic and traumatologic department, and only since 2 years and a half that I'm involved in the procedure of complication of orthopedic and traumatologic surgery, as dashed wounds, traumatic wounds, tissue loss, problems with pin site for the external fixation. But are many years that I'm involved in the preparing the wounds from the field of vascular wounds to, of course, traumatic or infected wounds. Recently, I'm focused on the traumatic wounds because also I am a medical doctor in the Army, and we are able to treat, to tackle with combat wounds, with trauma wounds, high energy wounds. And it's very simple for us, for this kind of specialist in Army, to deal with these wounds. And in this field, I'm able to apply the new frontiers of wound technology, just to compare the difference in the field of prevention and treatment, and also maintaining the healing. 3 different fields, but very linked between them.
Thank you, Professor Durante. What was your previous experience on radical oxygen species' role in the wound healing before using Reoxcare?
We can simplify the reactive oxygen species in ROS just to follow the discussion. ROS is very unstable molecules. They are very linked to many wound healing processes. We know essentially hydroxyl radical, peroxide, hydrogen peroxide, and superoxide anion. This is the most known oxidative radicals. And in the last probably 15 or 20 years, every attention of the specialists in wound care were focused on the stalled wounds, on the wounds blocked, stopped in the inflammation phase. In the in a few cases, the problems is related to the presence of microorganism or a bacterial load or a biofilm, is in microbial problems. Sometimes it's only an phlogosis, an inflammatory problems. It's not without microbial load. This is because the ROS they have a very important, a crucial role in many phases of the wound healing. For example, angiogenesis, cell proliferation, collagen and fibroblast production, and so on. But in a very precise concentration. The problem is the overabundance of ROS. And when the ROS is uncontrolled, there is an oxidative stress. The oxidative stress is able to stop, to give up all the healing process. Not only this, if you, in the last probably 30 or 40 years, in many television or many voices, not only restricted in the field, but the voice of the people, of the people in the street say, they say, the age, the mortality, the lethality of the cells in the old age depends on the oxidative stress. Everybody says this. Oh, take the antioxidant pills, take the antioxidant syrup, antioxidant stripes for your face. Yes. There are many true words in this, but the problem is the intracellular mechanism, because the ROS interfere with the intracellular signaling, and the intracellular signaling is the prompt reaction of the intracellular environment to the variation of the external environment. The cell is able to concentrate and produce and concentrate fibroblasts as it serves just to react, or macrophages or neutrophils. But when the neutrophils or macrophages are too present, are too in number present inside the wound healing, inside the wound bottom, in the bed of the wound, this is a problem, because they produce ROS, a lot of ROS inside the cell. And this is the problem, that the cell blocked his mechanism of energy production inside the mitochondrial environment. No energy, not life for cell, not restore and produce other DNA, no replication, no construction of the matrix. The ECM matrix is the most important structure of the cell, and without the restoration of the matrix, it is impossible to rebuild new tissue, new production of substance, tissue substance, just to restore the level of the tissue loss. And the hyperabundance of ROS are a problem also for oxidative phosphorylasis. It's another, as Krebs cycle, another mechanism of production, energy production. This is it's not very easy just to understand this. But in the last 2 years, I want to render more deep my knowledge about the ROS, because the oxidative stress is probably the most important obstacle to wound healing, to a normal wound healing. Because sometimes is easy also to avoid this oxidative stress, putting, for example, cellulose, collagen, because there are two new dressing able to tackle with the oxidative stress. But the result of the definitive healing as the scar is very different after this kind of pathway. The scar is scarring. It's not a normal scar, because there has been a process, a different process. It's not a regular wound healing process, and we notice this with the definitive result, the definitive outcome of the wound process, that is the scar.
Could you describe the cases where you have used Reoxcare? How was your experience using Reoxcare?
Reoxcare was a challenge for me many months ago, because I used all the formulation, the tablet, the matrix, and the gel. It's a challenge because it's a very natural product. The tablet, the matrix, is 100% plant-based, because it's a carrot tree, and there is also other antioxidant agents, oxidative scavenger as acetylcysteine, for example, or turmeric, and others. And we know that N-acetylcysteine is a very good oxidative agent scavenger. And the possibility to use a matrix that I'd like to call scaffold for our tissue restoration, and in the same time, just to follow the therapy with the gel is a very good chance for us, because we work in an orthopedic and traumatology department. And the leitmotif of our department is fill the gap. And when we have tissue loss, and we are sure that the bacterial load is not quite active, because we control with bacterial fluorescence imaging detection with a special device. And we look and we check this, and after we are free, we feel free to use the more correct wound dressing for the patient. And the possibility to use for the tissue loss a scaffold, just to fill the gap and have the complete adherence with the borders and with the bottom, and to have the possibility to change the dressing 2 times per week. And in this way we can manage with other patients in the outpatients or in the department, because 2 times per week will leave us free to manage with other clinical cases. It's not a very strict therapy control. And the presence of the contemporary presence of three antioxidant agents is very important for the traumatic and stalled wounds, because we are not able, unfortunately, to see the tissue loss immediately. But we saw patients after 2 weeks, 3 weeks, or uncorrected therapy, or malpractice of the wound. And in this way, we are able to tackle the stalled, the inflammatory phase that is stable in this kind of patient with malpractice. Also, we have the possibility to use the gel, and the gel is very rich of other factors of anti-inflammatory factors, as ascorbic acid, alpha-tocopherol. Alpha-tocopherol is like a corticosteroid similar. Is a very anti-inflammatory agent. And the gel is also very active for the autolytic, as the matrix, because there is the osmotic of the related to the composition of the dressing, the carrot tree, and the osmotic and autolytic, the bride. And in the same time, we are fighting with, because I am a military surgeon, we are fighting with the inflammation, the stable inflammation, with the devitalized tissue on the bottom, and we have a complete adherence of the dressing inside, because if we use the scaffold, we can feel after moist the scaffold, we can feel completely the tissue loss with the matrix. Just to enforce this concept, recently we are using the matrix as a scaffold for platelet gel. We put the platelet gel and over with the scaffold, and close with the secondary dressing foam, probably the most part of the case, and just to reinforce the effect of the platelet gel to stay in the wound bed, with the possibility just to fill the matrix with the growing cells on the bottom of the wound, just to stress the concept of the matrix, because the term matrix is very, very important and is very easy for comprehension the potential action of this dressing when it necessary a very strong reply from the tissue.
So, from your knowledge, what are the main advantages of Reoxcare?
In our experience, especially in 2 cases, we noticed the important activity of this kind of dressing in the special condition. The 2 cases that I want to refer is, first of all, a surgical discence in the lower leg in an old woman after the removal of an important epithelioma. The surgeon, it's not a case of my hospital, they put many stitches in this huge tissue loss they performed just to remove the epithelioma without a drainage, correct drainage, and there was a complication as seroma, very big seroma and the consequent wound dissence with the complete opening of the wound. The problem is the anatomic localization, because in the leg, not in the thigh, but of the leg, the tissue is the subcutaneous tissue is not very represented, because there are many structures in the leg, tendons, bones, vessels, muscle in a very restricted space, and the presence of so close important tissue as the vascular bundle or the bone, the periosteum, and etc. They limit the normal restoration of the bottom of the wound. And we performed first of all bacterial fluorescence imaging detection with a special device, just to be sure that there are no important microbial load. But we found bacterial charge inside, and we use antibiotics, systemic way, of course, not local. And after this initial treatment, we put the negative pressure wound therapy with a special device, not the big one, but it's a mechanical one, just to stimulate the bottom and the side, the two sides of the bottom, the wound, because in the definitive effect of this cavitation of the wound dissence is very deep. After this, we gain some millimeters from the wound bed, and we put the matrix. The patient was followed at home as a home patient, and the nurses of the hospital followed her for 3 weeks, putting the dressing 2 times per week. And at the beginning of the experience, we put the entire dressing, filling all the gap. Following the case, we have been able to reduce the piece of the matrix, adapting it to the bottom of the wound, just also to have a reduction, just to have the control of the reduction of the sides, because the initial matrix was too big to put in the bottom of the wound. And in 3 weeks, we reduced we filled the gap just to arrive at the level of the skin of the vital skin around the perilesional skin. And after this, we changed, of course, the dressing in another dressing. In the specific case, we use the non-adherent dressing with gel, because the gel is also in a moisturizing, and with non-adherent dressing as is not a paraffin gauze, but is a synthetic gauze with petroleum derivated, of course, but it's not with paraffin inside. And with the gel and this secondary dressing, we follow the healing to the definitive outcome. There is a complete restoration of the skin lower of the epidermis. Of course, there is a a scar, because we fill the gap with new tissue, and it is not a very organized tissue as normal, of course. The scar is a normal step of the healing when we are to fill a gap, and this is impossible to close directly the skin. But this is a complication of direct closing the skin, but it's a very, very good outcome, cosmetic and function. And the other case is a trauma lesion, a trauma wound of the sole of the foot. Is not not weight bearing, because it's in the middle of the foot. But we tackle the skin, the wound after 3 weeks after the trauma, and he followed the therapy by another hospital with iodopovidone gauze inside, paraffin gauze filled of iodopovidone, fluid iodopovidone, and we saved his foot with the application. At first step, we performed the debridement, because there is a dressing residual of povidone and paraffin gauze inside, and we perform two surgical debridement, and with a position of an antiseptical, antimicrobial dressing. And after the second application antimicrobial dressing, we changed with the 100% plant-based matrix. And we cut the matrix on the person sides as a tailor inside the plantar wound, and we put it for 2 times. At the beginning 3 times per week, every 48 hours, because he was our outpatient in the clinic of the department. And after, we changed the frequency at 2 dressing per week. And the foot is not a very easy anatomical localization for speed healing, but we wait for 6 weeks to reach the complete recovering of the tissue loss. And we perform, of course, the complete healing with, in this case, with gel, and with non-adherent dressing, but with hydrofiber. Reoxcare gel and hydrofiber, simple normal hydrofiber. The hydrofiber remains attached to the external layer of the reparation, and we didn't touch the hydrofiber, and remove the hydrofiber when the healing is completed with the complete revitalization of the foot.
Thank you, Professor Durante. Thanks for your testimonial. And we are sure that with your experience and your knowledge, it will be very useful for any practitioners that want to use Reoxcare. Thanks very much.